Good afternoon, everyone. Welcome to the California Prevention Training Center's STD Expert Hour webinar series. We're very happy today to have a local and national expert, Dr. Kim Ehrlich, joining us to talk about genital herpes. Before he begins, I'm just going to go through a couple bits of slides for you. First, just to give you a little bit of information about the California Prevention Training Center that's hosting this webinar. We are a part of a national network of prevention training centers funded by the CDC STD control and prevention. We provide trainings to a host of target audiences, medical, health promotion, and community professionals that are serving persons in communities impacted by STDs and HIV. We also have a host of resources up on our website. That's www.californiaptc.com. We have links to prior STD expert webinars, video recordings. We also provide technical assistance and clinical precepting. We are part of a national network that provides clinical consultation. It's an online service at www.stdccn.org. So if you have a challenging STD question, you can go to that website, put your question in, and you will get a response in 1 to 5 working days, just depending on the urgency of that particular question. It's a great resource for a national resource. All right, next slide. Okay, so in terms of upcoming webinars, I'm really happy to announce today that our next STD Expert Hour webinar is going to be on HPV. We're going to have Dr. Aina Park joining us. That's going to be in October. And we have a couple of upcoming in-person STD updates. The next one's going to be in Phoenix, and that's free CME as well. And if you have questions about upcoming trainings, you can contact Dominique Remnick. Her email is listed on the slide. We also have a social media presence. You can find us on Facebook as well as on Twitter. And for today's webinar, we really want to hear from you. So I just want to introduce some of the things that you're seeing on your webinar slide. So there's a chat box that's at the bottom of the slide. And that, whatever you type in that chat box is going to go out to everyone that's registered and viewing this webinar. And right now we have about 250 participants that are listening in. We have 800 that are registered, so we'll see how many actually are able to attend today. Please, everyone, if you can, sign in on the sign-in poll, which is also right below the webinar screen. That gives us your name, your email, and if you want to get continuing medical education credits or CEUs, we need your license number. You can sign in that sign-in poll. If for some reason you haven't registered yet for this class and you want to register, if you look under the resources box, you'll see there's a late registration link. So you can go there if you want to register, and then that registration will be used for CME reviews. So now we're going to go and test our first poll. So this is an audience poll to try and figure out how many people are listening in. So if folks can type your answer into that poll, that gives us an idea of if there are multiple people listening at one computer screen. So we have more of an idea of how many people are listening at your particular site. We'll just take a moment, and we will be having other polls that are going to take place during this webinar. When Dr. Ehrlich has questions, an audience poll will pop up on the screen, and that's where you can type your answer in. So I think we can probably close that poll now. Thank you. So in terms of disclosures, neither myself or Dr. Ehrlich have any disclosures today. You can get CMEs and CEUs. There's one credit. In terms of how to go about that, during the training, as I mentioned, if you go to the sign-in poll and put in your name, your email, and your medical license or your nursing license, then after the training, you'll receive an online evaluation that will be sent to you. And that will be sent to the email that you use for registration. And then you will receive your certificate via that mechanism after you complete that online evaluation. If there are any questions about continuing education credits, you can always contact Dominique Remnick. So I hope that you enjoy the course today. And I want to introduce our speaker, Dr. Ehrlich. It gives me great pleasure to introduce him. He has been a longtime faculty for the California Prevention Training Center, teaching at some of our fundamentals courses over the years. He's an associate clinical professor at the University of California, San Francisco. He's board certified in the field of infectious diseases. His practice is in the San Francisco Bay Area, caring for patients with infectious diseases, and he is the chief of staff, the medical director of infection control and prevention, and the director of antibiotic stewardship at the Mills Peninsula Medical Center in Burlingame, California. He has published numerous research and clinical articles on herpes simplex virus and other sexually transmitted diseases. So it gives me great pleasure to welcome you, and I'm going to turn this webinar and this webcam over to you, Dr. Ehrlich.
Great, thank you very much, and good afternoon or good evening or good morning wherever you are. I want to thank you all for attending, and what I'd like to do with the next 45, 50 minutes or so is talk to you about genital herpes. What we'll do is we'll be talking about the diagnosis, the management, and the prevention of genital herpes, and the objectives for the next session will be to discuss and describe the changing epidemiology of genital herpes, both HSV1 and HSV2. We'll talk about the clinical presentations and common complications. I will update you on the state-of-the-art diagnostic tools that you should be using when you see a patient with suspected genital herpes. And of course, we'll talk about the current treatment options and prevention options, way to prevent your patients from acquiring genital herpes. We'll touch on some critical counseling issues, and I will end by talking about some of the newer developments in terms of medications that are coming down the pipeline, as well as the answer to that question, where is the herpes vaccine that we've been promised for so long? As Sharon mentioned, I have no real conflicts of interest in terms of off-label discussions. I might be mentioning the use of antiviral medications in a way that might not appear in the FDA-approved package insert, but everything that I'll discuss is included in the Centers for Disease Control, STD, guidelines. So genital herpes, as you all know from taking care of patients with sexually transmitted infections, genital herpes is a real issue. Patients come in with symptoms, they come in with fear, and certainly genital herpes, despite the fact that we have treatments out there and we have strategies to try to prevent it, is still a fairly scary topic for many of our sexually active patients. Now, what we need to understand is that the prevalence of herpes is quite high, both in the United States and globally. Most cases of genital herpes are due to herpes simplex type 2. Now, keep in mind there are two different types of herpes simplex virus, type 1 and type 2. I suspect that thousands and thousands of years ago there was just one HSV type, but over time mutations occurred and we now have two different unique strains. And what makes them interesting is that herpes simplex virus type 2 is more likely to cause genital herpes, and whereas herpes simplex virus type 1 is more likely to cause oral labial herpes. But having said that, either herpes type can infect any anatomic location, and as I'll talk to you about in a bit, we are seeing an increased incidence of genital herpes due to HSV type 1, particularly in women and in men who have sex with men. Now, even though either virus can infect any anatomic site, including the genital tract, those patients who present to your clinic or to your office with frequent genital herpes recurrences, someone who comes in and says, you know, I'm getting an outbreak every 3 weeks or once a month, chances are, more likely than not, that's going to be herpes type 2. Herpes type 2 tends to recur more frequently in the genital tract than does herpes type 1. When we look at the risk factors for patients acquiring genital herpes, it's similar to other sexually transmitted diseases. Increasing sexual activity, increasing numbers of partners, and the presence of other sexually transmitted infections are all risk factors for acquiring genital herpes. Now, in 2008, the Centers for Disease Control looked at the estimated number of new sexually transmitted infections in the U.S. And what they found back then was that if you look at herpes simplex virus type 2, about 750,000 new cases of HSV2 were being diagnosed yearly. And about 45% of those, a little less than half, were in a young age group between the ages of 15 and 24. Now, because herpes is a lifelong infection, that once you become infected, you remain infected for life, when you look at the total prevalence of HSV2 in the same year, in 2008, it was estimated that there were 24 million individuals in the U.S. with herpes simplex virus type 2, second only to patients with human papillomavirus. And both of those, of course, are chronic infections in many individuals. Now, you know as I know that patients are coming to our offices and clinics frequently with complaints of genital herpes. And when you look at the CDC report on number of office visits in outpatient centers, you see that year after year, increasing number of visits to physicians' offices with complaints or diagnosis of genital herpes infection. So let's start with a poll. Okay, put on your thinking caps. Approximately what percentage of the U.S. population between the ages of 14 and 49 actually have HSV2? A would be 2%, B 12%, C 25%, D 50%, or E 75%. We'll give a couple of minutes for people to respond. Okay, we'll pretty much stop there. So the majority of people said about 25% of the U.S. population is infected with HSV2. When you look at the numbers, what you find is that it's more along the lines of 12%. This is the most recent data from the National Health and Nutrition Examination Survey, which did type-specific seroprevalence in individuals ages 14 to 49, and found if you look at the entire U.S. population estimated in that age group between 14 and 49, about 12% of the population has HSV2. It varies based on age. The older individuals between 40 and 49 had over a 20% seroprevalence rate, and it also varies depending on ethnicity. African Americans have a higher seroprevalence rate than Caucasians or Asians. When you look at this a different way, looking at the number of males and females, or at least the percentage that are seropositive, you can see that more females are infected with HSV2 as demonstrated by positive antibody titers as compared to males. And both incidence of HSV2 in males and females is higher than what we see for trichomonas, chlamydia, or gonorrhea, but less that for HPV and for bacterial vaginosis in females. Looking at the incidence between men and women, 1 in 6 women has seroprevalence of genital herpes compared to 1 in 12 men. So it is a disproportionately affecting women more than men. Now the good news with HSV2 epidemiology is that we have seen a steady decline over time. When you look at the data between 1999 and 2016, there's been a drop from 18% down to about 12% in terms of total overall seroprevalence and infectiousness. This may be because of our wide use of antiviral therapy, better counseling, better awareness of HSV, and perhaps less transmission over time. Well, what are these viruses? So these viruses, herpes simplex virus, both type 1 and type 2, are DNA viruses. They have a circular nucleoprotein core surrounded by an outer protein capsid made up of 162 subunits called capsomeres. This naked virus particle is then surrounded by an outer lipoprotein envelope, and expressed on the surface of the lipoprotein envelope are various glycoprotein antigens. And these glycoprotein antigens are required for infectivity, and we actually use these to differentiate HSV2 from HSV1, particularly glycoprotein GG, the one at the bottom left-hand corner. There's little cross-reactivity between HSV1 and HSV2, and when we do type-specific serology, we're determining whether an individual has antibody to that particular antigen of the HSV. Well, let's look at the signs and symptoms of patients with genital herpes. What we know is that patients who develop genital herpes for the first time and have not had previous infection with the other HSV type have what we call primary infection. And this tends to be a little bit more severe in terms of symptoms than the individual who, say, was already infected with HSV type 1 in the mouth or nose and then gets genital herpes due to HSV2 for the first time. That would be considered non-primary first episode. So the more severe is the primary first episode. Typically, these patients present with tender vesicles. These small vesicles are unroofed to form shallow ulcerations. There's local pain and itching at the area of the lesions themselves. And there can be some dysuria, even if the person does not have urethral involvement with the viral infection. In women with first episode genital herpes, a majority will have some cervicitis with an abnormal vaginal discharge. And patients with first episode herpes will often have tender inguinal adenopathy. And the presence of the tender inguinal adenopathy helps differentiate genital herpes from other causes of genital ulcer disease, such as syphilis, which tends to give you non-tender adenopathy. For people with first episode herpes, systemic symptoms are not uncommon. About a third of individuals may present with low-grade fevers, headache, myalgias, and even meningismus or stiff neck. Looking graphically at the course for patients with genital herpes, there may be a 2 to 12-day period of incubation from the time of exposure until the time that symptoms develop, and during that time the virus is actually establishing dormancy and latency in the nerve ganglia. Once symptoms develop, again, they start off with small vesicles. These vesicles rapidly turn into pustules as the body effluxes white blood cells into this highly infectious vesicular fluid. If left untreated, it may take 5 to 7 days or so before the vesicles will start to unroof, forming wet ulcers, and these moist ulcers, easy to demonstrate live virus in these lesions as long as they remain moist. They tend to dry up over time, and by about 12 to 14 days or so, the ulcers have all dried. Crusts tend to form on them. They then heal by reepithelialization, typically leaving no scars. It's easy to demonstrate live virus in these ulcers and vesicles as long as the lesions remain moist. Once the lesions have dried out, however, your virus cultures are more likely to be negative, and if you want to try to use a diagnostic test at that point, you might want to use the PCR, which may still be positive even if the lesions are dry. This is a typical patient with first episode genital herpes at the top. You can see lesions scattered throughout the genitalia, and the same individual during one of his recurrences where he has a small, well-circumscribed crop of vesicles, and he'll get recurrences in the same spot each time that he develops a recurrent outbreak. Here's a woman with first episode genital herpes, and we suspect it's first episode. Why? Well, she's got lesions on both sides of the midline. It's more common to have bilateral lesions during first episode or primary infection, much more likely to have just unilateral lesions on one side during recurrences. Many of these lesions you can see are already unroofed and ulcerated. There's a few clear vesicles that still remain. Another woman with severe first episode herpes, you can see the lesions are starting to dry out in some fashion. Some of them remain vesicular, a lot of erythema surrounding these lesions. Now I mentioned that herpes tends to cause latency, and how does it do that? Well, the pathogenesis of herpes infections, no matter where they infect the body, be it the genital, the nasopharyngeal area, or any other mucous membrane or skin lesion, the virus will penetrate the skin or mucous membrane with a little bit of local replication, but the virus then gets onto a nerve fiber and travels in a centripetal fashion along the axon to reach the nerve root ganglia. Once the virus gets to the nerve root ganglia, it establishes itself into a latent state, incorporating its DNA directly into the ganglionic cells. Once that occurs, the virus can now travel down in a centrifugal fashion in the opposite direction, getting back to the skin or mucous membrane, causing the typical lesions that go along with symptomatic first episode or recurrent genital herpes or herpes anywhere. And the reason this is important is that when a patient presents to you with symptoms, no matter how quickly you intervene with antiviral therapy, you don't affect the fact that latency has already been established in these nerve ganglia, and the patient is at risk to develop reactivation with recurrences down the road. Well, let's look at the signs and symptoms of recurrent genital herpes, because this is probably the more common patient who presents to our clinic or offices. Typically, the lesions are less extensive in distribution as compared to that same patient presenting with first episode herpes. The illness tends to be milder than we see during first episode primary, and typically there are only local symptoms. You don't tend to see the fevers, the malaise, the stiff neck that may go along with first episode. But having said that, we all know that for many patients, for many of our clients, herpes is a very psychologically devastating infection to have. Why? Well, because it is a lifelong infection and tends to recur. So when patients do present to you with severe symptoms related to their reactivated herpes, rather than just throw more antiviral drugs at them, it's sometimes wise just to sit down, take the time to explore what this diagnosis of herpes really means to them. For many patients, it's more the psychological pain than it is the physical pain. The frequency of recurrent herpes can be quite variable. Some people will go a whole year or more without a symptomatic outbreak. Others will get outbreaks every month or even more frequently. There may be several reasons for that, and many times we're not sure why that is. A prodrome may be present. Some patients will say, you know, I can always tell when I'm about to get an outbreak. A day or two before I notice the lesions, I get a little burning, a little paresthesia, a little itching, a little tingling, and you can use that information to your patient's advantage and actually allow them to start antiviral therapy as soon as they feel the prodrome. and in many instances completely abort an outbreak from occurring. This is a graph of a patient with genital herpes that has recurred, and you can see it's similar to the one I showed you earlier, but a little more squished together. There may be a 1 to 2 day period of prodromal signs or symptoms before the vesicular lesions are noted. The vesicular lesions may last very transiently. Patients, many times they say, I don't even notice the vesicle, I just notice the ulcer and then the crust happening right away. Just like with first episode, you're able to demonstrate live virus as long as the lesions remain moist. But with recurrences, they can crust over within a matter of a few days, and you may not get positive virus cultures at that time. And here's a patient with recurrent herpes. You can see it almost looks eczematous with more of a crusting appearance to the lesions rather than vesicular. Another woman with an atypical episode of recurrent herpes. These lesions don't look punched out in circular, they more look linear. And we do know now that many people present with very atypical lesions when it comes to their recurrent herpes. This is an immunocompromised woman who developed recurrent herpes, and you can see how large and extensive it was. A single lesion that continued to enlarge due to her underlying immunocompromised condition, and this can be very difficult to treat in our compromised hosts. Perianal herpes is not uncommon, even in individuals who have not had anal receptive intercourse. But here's a woman with recurrent herpes of the buttock area due to HSV type 2. This recurs in the same fashion that someone with genital herpes does. The virus is reactivating from the nerve ganglia that feed that particular area. And certainly in our immunocompromised hosts, many years ago in the early AIDS era, where we had very severely immunocompromised individuals, we saw extensive perianal herpes that was very difficult to treat despite using high doses IV antivirals. And in fact, in the immunocompromised hosts, there is a risk of drug-resistant herpes from developing, and it often occurs in people with very extensive disease like this and very poor immune response, where the normal mutations that occur leading to resistance can then overgrow and cause latency. Now, we talked about HSV2, but I also mentioned that HSV1, herpes simplex virus type 1, can cause genital herpes as well. Well, what is the prevalence of herpes type 1 in the United States? Well, unlike HSV type 2, HSV1 is actually much more common. If you look at the total population, almost 50% of the U.S. has antibody to HSV1. Most of these people had oral labial herpes. Many of them acquired it as a child. But because of the high incidence of HSV1 nationwide, you can imagine why we are seeing more herpes simplex type 1 genital infection from occurring. Now, HSV1 prevalence has decreased over time as well, looking from 1999 through 2006, maybe not quite as dramatically as HSV2, but still roughly 50% of the population is infected with HSV1. Typically, HSV1 causes gingivostomatitis, or the classic fever blisters or cold sores as depicted here. Again, a small crop of vesicles reactivating in the same location over and over again at the vermilion border. These lesions can crust and become unsightly. In immunocompromised patients, they can be quite severe. We see this in our hospitalized patients, say individuals on chemotherapy or steroids who have a large febrile illness. They may reactivate their HSV1 in the hospital. But more often than not, they're more mild in our outpatient arena, but this is live virus, and this can spread through genital oral contact. And in fact, when we look at the increased incidence of genital herpes due to HSV1, why is it? Well, it probably has to do with increasing oral genital contact, leading from transmission from the mouth sores down to the genitals, where primary infection can occur. Now, herpes can infect any anatomic location, as I mentioned, and always keep your index of suspicion high when you see a mucous membrane or skin lesion elsewhere. This is herpetic Whitlow, a painful or itchy, pruritic, nodular, vesicular, ulcerative lesion occurring on the fingers. This virus is dormant in the nerve ganglia that feed that finger, and it will reactivate every so often, causing these typical lesions. This is actually the breast in an area who is bit during a period of passion and wound up with HSV1 infection of his breast area. This too reactivates over time as the virus has become dormant in the nerves that feed that particular area. Now, this is the cervix, a colposcopic view of a woman with first episode genital herpes. and you can see the cervical os, and you can see the lesions, the vesicular lesions, covering the cervix. Well, if this woman were pregnant, let's say, and if she was going to go into labor and the os was going to dilate and the baby was going to come down through the canal, it's easy to imagine that the baby would certainly be at risk of coming in contact with virus and possibly developing the devastating complication that we refer to as neonatal herpes, or herpes neonatorum. Neonatal herpes comes in two varieties. The more severe involves the central nervous system. The less severe just involves the skin or mucous membranes. What we know about neonatal herpes is that it occurs about 1,500 times per year in the U.S. Estimates are between 1 in 3,000 to 1 in 20,000 live births. The risk of a woman having a baby with neonatal herpes is much higher if that woman has developed her first episode of genital herpes during pregnancy, particularly during the third trimester. What we know is that initial infection during late pregnancy may be due to the partner infecting the woman for the first time without knowing it through asymptomatic shedding. Now, of course, what's more common is a woman who's had herpes in the past and now gets pregnant, and maybe she develops reactivated disease during pregnancy. Is she at risk of transmitting to the baby? Much less so. There's a much lower risk for recurrent disease during pregnancy. Why is that? Well, think about it. If the woman has already had herpes for many years, she's had a chance to make antibody, IgG antibody, which will cross the placenta and protect the baby. So even if that woman were to be shedding virus at the time of vaginal delivery and the baby came in contact with the virus, the baby's got mom's antibody on board and protects the baby against getting infected. The more dangerous scenario is the woman who's acquired herpes for the first time during pregnancy. She has not yet had a chance to make IgG antibody, so the baby comes down through the canal without mom's antibody on board. Baby gets exposed to the virus and is much more likely to become infected. So how do we prevent neonatal herpes? What strategies do we employ to try to keep this from occurring? Well, there's been a lot of discussion about that. Certainly, pregnant women and their partners should be asked about whether they're known to have herpes. It's not recommended to routinely do serologies in all pregnant women and their partners, but on a case-by-case basis, it might be appropriate. If you found that a couple was discordant, meaning the male partner is known to have HSV2 or tests positive for HSV2, but the woman is negative and has no evidence of prior HSV2 infection, you certainly don't want her to get infected during pregnancy. What would I do there? Well, I would tell them to avoid unprotected intercourse, particularly during the third trimester, and I would consider putting the male partner on antiviral suppression to suppress his herpes and keep him from accidentally transmitting to the pregnant female partner. You could make the same argument for individuals who are HSV1 discordant. That is, if a woman is known to be negative for HSV1, but the man is known to be positive, say he's got a history of cold sores or fever blisters, you would tell them to avoid the woman to avoid receptive oral sex during that third trimester. Now, we also use antiviral suppression late in pregnancy for women who are known to have herpes. What we know is that if you take women with a history of genital herpes who are pregnant and put them on antivirals from 36 weeks on, it does reduce the chances of them shedding virus at the time of labor and reduces the need to do cesarean section. Although we think this would reduce the incidence of neonatal herpes, and it is a strategy which is widely used, it hasn't actually been proven to reduce neonatal herpes. But be aware that the blood testing is out there, and some pregnant women may come to you with their partner asking to be tested. This is actually an article from a magazine that sits in OBGYN's offices. I think it's called Fit Pregnancy, telling pregnant women to request that your physician or your healthcare provider test you and your partner for antibody to HSV2 to know if you're discordant. So let's go to another poll question. We talked a little bit about asymptomatic shedding. So the question is, most people with genital herpes know that they're infected with herpes. Is this true or is this false? Numbers are coming in, and overwhelmingly, I think we'll end the poll because it's clear that the majority of people have the correct answer there, and that is that most people do not know that they're infected. The majority of people with herpes simplex virus type 2 or who test positive on serologic testing have not had symptoms that they recognize as being genital herpes. when you ask them detailed questions, they may say, well, yeah, I do get occasional irritation, occasional redness, occasional itching, but I just thought that was, irritation from my clothes or jock itch or a yeast infection or whatever. The majority of people with genital herpes don't know that they have it. And the reason this is important is because everybody with genital herpes sheds virus asymptomatically a certain percentage of the days that they have no signs or symptoms, and they're contagious during that time. We describe and define asymptomatic shedding as the presence of virus in the absence of symptomatic or visible lesions, although, as I mentioned, sometimes symptoms may be minimal or atypical, and patients can be educated as to what their recurrences actually look like. We think that asymptomatic shedding occurs in all patients with genital herpes, but frequency can be quite variable. The rates actually depend on which test you use, culture versus a PCR, PCR being more sensitive. What we do know is that asymptomatic shedding rates are much higher shortly after the initial infection. So somebody who has their first episode of genital herpes is going to be shedding asymptomatically much higher in that first year or two than they will, say, 10 or 20 years down the road. We think that asymptomatic shedding is instrumental in transmission to asymptomatic uninfected partners. And of course, the question that I get, and I'm sure you get as well, when you have a discordant couple sitting in your office, one person's known to be infected with herpes, the other is not. They want to know, well, doc, what is our risk of transmission? What is the risk of transmission from the infected individual to the uninfected individual? Well, obviously this depends on a lot of factors, frequency of sexual contact, frequency of symptomatic outbreaks and asymptomatic shedding. But when you look at the studies, it looks to be about 10 to 15% per year, and that's the number that I tend to use. Some of this data came from an old study, which was a failed vaccine trial, in which 144 discordant couples were followed for almost a year, and they found that the risk of transmission was almost 10%, and that 14 of the 144 couples shed virus and transmitted to a sex partner during that 11-month period of time. Well, now, not everything that ulcerates the genital tract is genital herpes, so what else do we think about in our differential diagnosis? Of course, we're talking about genital herpes, but the other classic causes of genital ulcer disease include syphilis, chancroid, lymphogranuloma venereum, and rarely granuloma inguinale. There are some non-viral infections as well, trauma, bacterial cellulitis, fungal dermatitis, primary immunologic or skin conditions, or fixed drug eruptions, all which should be considered in the atypical person with genital ulcer disease. Here's a woman with syphilis. She's got both condyloma lata and the ulceration, the primary chancre. As I mentioned, the syphilis lesions tend to be non-tender, unlike the herpes ulcers, which tend to be tender, and syphilis tends to give you non-tender inguinal adenopathy. Another individual with a primary chancre from syphilis. This doesn't look like herpes typically, but of course these lesions can be atypical as well in their appearance. Chancroid, not very common, caused by Haemophilus ducreyi, also very tender lesions. Lymphogranuloma venereum, due to some strains of Chlamydia trachomatis that can cause ulcerative disease. And uncommon, but granuloma inguinale, also can cause genital ulcer disease and appears in the differential diagnosis. Okay, what about testing? Let's take another poll. So let's say someone comes into you with genital ulcer disease and you decide it's worthy of a laboratory test. What is the best test to diagnose herpes in a symptomatic patient? Would you use the Zank smear, the direct fluorescent antibody stain, herpes simplex virus culture, herpes simplex virus PCR DNA assay, or the serology, the blood testing? A lot of respondents. We'll go ahead and close the poll. Most of you have said herpes simplex virus culture, and second has been the PCR DNA assay. This was kind of a trick question because those are both correct answers. Both the PCR DNA detection assay and virus culture are the primary tests for diagnosing patients who come in with genital herpes suspicion. The PCR is increasingly widely available, has a very rapid turnaround time, very highly sensitive and very highly specific. The virus culture has been the gold standard for quite some time. It too is widely and readily available with a rapid turnaround time, highly sensitive and specific. The advantage of virus culture is it does allow you to do susceptibility testing if you thought someone had drug-resistant virus. Again, that's not very common. We see it mainly in immunocompromised individuals. But either of these tests should be available to you in your clinic, and if you have someone with genital herpes, an active ulcer lesion, and you want to test for herpes, either of these would be acceptable. Now, the serology is an important lab test as well. This is detecting antibody. It's not very useful for the person who comes in with first episode lesions because it takes a while for the antibody to turn positive, but it can be useful in certain circumstances, which we'll talk about in just a second. The other two tests that I gave you availability for, antigen detection, such as the DFA stain or immunoperoxidase stain or the Zank smear, these are less useful or not at all useful, and we should pretty much abandon these as our diagnostic tools. This is, by the way, is a virus culture. When the laboratory tells you that they have a positive herpes culture, what are they telling you? Well, what they've done is they've taken the specimen, they've inoculated it into cells which grow in a fibroblast type linear configuration, and when you see these ballooning degeneration, these cells that turn into spheres and fall off the glass slide, these are the cells which are infected with herpes simplex virus. Now let's go back to the blood test, the serology. What is the blood test and why is it useful in certain circumstances? Well, I mentioned earlier, we can exploit the glycoprotein G on the surface of the virus to determine if someone has antibody to HSV1, HSV2, both viruses, or neither viruses. Type-specific herpes serologies, there's two types. There's laboratory-based and point-of-care testing. Sensitivity is pretty good, anywhere between 80 to 98% sensitive, although there are false negatives, particularly early in infection. So someone who comes in with first episode lesions, and it might be first episode or primary herpes, you might get a negative serology at that time. Might make more sense to test them 4 to 6 weeks down the road. Well, what do you do with these results? Well, if you have someone who tested positive for HSV2, what that tells you is it's much more likely to mean that the person actually has genital herpes, whether they have symptoms or not. Because most cases of HSV2 involve the anogenital tract, a person who tests positive for HSV2 on type-specific serology, chances are they've got latent genital herpes. Now, for the person who tests positive for HSV1, that's a little bit more difficult to interpret. As I showed you earlier, almost 50% of the U.S. population test positive for HSV1, and the majority of those individuals actually have oral labial herpes and don't have genital herpes. But if you had someone who came in with a suspicious genital lesion, they've had oral genital contact, they test positive for HSV1, they've never had oral herpes before, certainly it could be indicative of them having genital herpes due to HSV1. The other take-home message I want to leave you with is to not do IgM assays with your blood testing. You know, in all of us in our training, we were trained to believe that IgM antibody occurs early in the course of infection and then disappears as infection becomes older and older, and you have just IgG. That's still true for a lot of infections, but not for herpes simplex virus. So individuals who've had herpes for many, many years may still have detectable IgM antibody. So a detectable IgM antibody does not diagnose a person as having recent infection. So when should we use these type-specific IgG, glycoprotein G-based serologies? Well, I can think of a few scenarios where they might make sense. Let's say you have someone who comes to you with recurrent or atypical symptoms. Maybe you've taken a herpes culture or PCR and it's negative. And you're wondering, well, maybe I just aren't seeing you when you're having the active viral outbreak, and you tell me you're having lesions that are occurring every couple of months or so, but we're just not, you're not coming to the clinic when you have an active lesion. You might do the serology then. You also might do the serology in someone who comes to you with a diagnosis of herpes, but they have no symptoms and there's no laboratory confirmation. Let's say someone said they were diagnosed with herpes 5 years ago and they've been on antivirals ever since, but no one ever confirmed that diagnosis with a lab test. You might do the serology then. As I mentioned, for the possible discordant couple, you might test the asymptomatic individual who has a known HSV-infected partner to see if he or she is actually at risk of acquiring the infection or not. And you could consider using serology in individuals where, say, they have an STD evaluation and have had multiple partners, say they're HIV-infected, or they're men who have sex with men and who is at risk for HIV infection. All of those are considered reasonable times to consider using the serology. But when should you not use the serology? Well, it's recommended that we don't screen all asymptomatic patients with the HSV serology. It's recommended that we not screen all pregnant women for herpes, and we should try not to test those patients who come into the clinic and want to be, quote unquote, tested for everything. I know you see those patients. I do as well. Someone who comes in and they're feeling a little guilty about something that might have happened, and they want to be tested for everything. But what should you do when a patient requests or insists on being tested for herpes? When they say, look, I know there's this blood test. Doc, I want you to test me for herpes. I think at that point you really need to sit down with the patient and talk to them about what they're going to do with the results. If they test positive for HSV2, are they going to disclose that to their future sex partners? Are they going to use condoms with every sex act? Are they going to put themselves on antiviral therapy? If the answer to those are yes, and they are going into this with their eyes wide open, then maybe doing serology in that instance may make sense. However, in November of 2016, the U.S. Preventive Services Task Force does say they recommend against routine serologic screening for genital herpes in asymptomatic adolescents and adults, including those who are pregnant. So this is the current recommendation by the U.S. Preventive Services Task Force, not to test people routinely. What about treatment? Let's go to treatment. Certainly patients come to us all the time with their herpes, and they want to know what's out there, what treatments are available, what can we offer them to make the lesions get better and potentially to reduce their chances of transmitting to a sex partner. So let's do another poll. So you've heard of these three drugs. Which drugs are effective in the treatment and suppression of patients with genital herpes? Acyclovir, valacyclovir, famciclovir, or all of the above? Overwhelmingly, most people have said all of the above, and indeed that is the correct response. Now, there are many antivirals that are available that have activity against herpes simplex virus type 1 and type 2. The oral drugs listed, acyclovir, valacyclovir, famciclovir, as well as ganciclovir and valganciclovir, but those two latter drugs we don't use for herpes. And in terms of IV therapies, there are several drugs which have activity against herpes, but the ones that we worry about in treating our patients are oral acyclovir, valacyclovir, and famciclovir. And for patients who require intravenous therapy, acyclovir is the drug of choice. Some of these other drugs, the IV drugs, the foscarnet and cidofovir, we might use occasionally for the patient with drug-resistant herpes, but that doesn't apply to the outpatient arena. Now, all of these drugs act in a similar fashion. All of these drugs are essentially inactive in their native form, but when a cell becomes infected with herpes simplex virus or varicella zoster virus, one effect of the cell being infected is it creates an enzyme, a viral-induced enzyme referred to as thymidine kinase. One effect of viral thymidine kinase is to tack a phosphate group onto the antiviral, in this slide showing acyclovir being turned into the monophosphate intermediate. Once these drugs become monophosphorylated, host cellular enzymes then kick in, tacking on two more phosphate groups, turning acyclovir into the active drug, acyclovir triphosphate, which directly inhibits viral DNA polymerase and directly incorporates itself into the replicating viral DNA chain, resulting in early chain termination. This is what happens with acyclovir, but the other two drugs, valacyclovir and famciclovir, are similar. Valacyclovir, as you know, gets turned into acyclovir after it gets absorbed and then gets triphosphorylated in the same fashion. Famciclovir gets turned into penciclovir once it gets absorbed, and penciclovir gets triphosphorylated in an identical fashion. So what's the difference between these three drugs? Well, the main difference between them has to do with the bioavailability. Acyclovir is only 10 to 30% bioavailable under the best of circumstances, whereas valacyclovir and famciclovir have a much higher bioavailability. What that means is that you get much higher blood levels when you take valacyclovir or famciclovir than you will when you take oral acyclovir. The 2015 CDC HSV treatment guidelines have been published, and I'm sure you all have familiarity with them or access to them. And I won't go into great detail, but all three of these drugs are approved for treatment of first episode or recurrent herpes. Acyclovir for first episode can be given 400 milligrams 3 times a day for 7 to 10 days. For recurrences, you can use the same regimen of 400 3 times a day for up to 5 days or so. Valacyclovir, you can use higher doses, a gram twice a day for first episode, and 500 milligrams twice a day for 3 days or a gram daily for 5 days for recurrences. And famciclovir, similar, 250 milligrams 3 times a day for first episode, 125 twice a day for 5 days, or a gram twice a day for 1 day. We do recommend higher doses and longer durations for immunocompromised individuals, particularly those patients with HIV infection. But what about suppression? As you're aware, taking these drugs reduce the chances that the person will have symptomatic recurrences and also reduce the incidence of asymptomatic shedding. Suppression has been a very useful tool for us to use in keeping our patients recurrence-free, reducing the risk of asymptomatic shedding, and in some instances, reducing the risk of transmission to a sex partner. The suppressive regimens that are recommended by the CDC include acyclovir 400 milligrams twice a day, valacyclovir 500 milligrams or a gram once daily, using the lower dose if the person has less than 10 outbreaks per year at baseline, the higher dose if they have more than 10 outbreaks per year at baseline. Or you can use famciclovir 250 milligrams twice a day. Now, when you're treating patients with herpes simplex virus, I want to list a few principles that I believe in. First of all, in treating somebody who comes in for the first time, be certain of the diagnosis. Again, not everything that's a genital ulcer is actually herpes, so it might be good to get a laboratory test to confirm. My feeling is that all first episodes should be treated, and the reason I say that is because the illness during that first episode can be severe and prolonged. But I always want to see the person back for follow-up. I want to discuss the epidemiology and the risks of transmission, and I want to present to patients the options of episodic or suppressive antiviral therapy. For patients with recurrences, it is okay to individualize. Not everybody with recurrent herpes needs to be treated, and if you do treat them, you can do episodic therapy, just giving them treatment when they have their symptomatic recurrences, or putting them on suppressive therapy to reduce the number of outbreaks, reduce asymptomatic shedding, and perhaps to reduce transmission to a sex partner. In terms of treating symptomatic recurrences, if you do treat them with antivirals, what we know, it's going to reduce the duration of the illness, reduce the shedding of the virus, and the best way to use it, in my opinion, is to let the patient have refillable prescriptions at home and let them start the therapy immediately during the prodrome or within 1 day of the symptom onset. If you do decide to put your patients on suppression, be aware that putting them on suppression reduces the frequency of recurrences and asymptomatic shedding and does seem to reduce transmission, particularly when using valacyclovir, as shown in that New England Journal of Medicine study not too long ago. Suppression does not need to be lifelong, but it is okay to continue it indefinitely if the person desires and if it makes sense for their lifestyle. These drugs are fairly safe and there's no need for routine blood or routine urine monitoring. And intermittent suppression is a useful strategy for some situations. Some people may say, you know, I'm going to go on vacation for a couple weeks. I really don't want to have an outbreak. I'm with my partner. They may go on suppression during that time, but may not want to be on chronic continuous suppression other times during the year, and that's fair enough. What we do know is that suppression reduces the risk of transmission. There was a study published several years ago looking at valacyclovir, in which over 1,400 discordant couples were randomized to receive either valacyclovir 500 milligrams daily or placebo. They were counseled to practice safer sex, and they were evaluated monthly for genital herpes. And what they found was that in the group where the infected individual in the couple received suppressive valacyclovir, there was a dramatic reduction, a 75% decrease in the incidence of symptomatic genital herpes transmission compared to the couples that were taking placebo. And in fact, when you compared the use of suppressive valacyclovir with using condoms, there was no transmission whatsoever. So when you have a couple in your office that's discordant and they say, what can we do to reduce the chance of the infected one of us transmitting to the uninfected partner? Well, putting the infected individual on suppression and using condoms with every sex act markedly reduces the chance of transmission to the uninfected individual. And based on this, the American College of Obstetrics and Gynecology has a level A recommendation saying that women with frequent recurrences should be on suppressive therapy, and for couples in which one individual has herpes infection, suppressive therapy should be recommended for the partner who has the infection to reduce the rate of transmission. Now, we know that it works with valacyclovir. What about the other two drugs? Do famciclovir and acyclovir work just as well? Well, we don't have a lot of good data comparatively. What we do know is that if you compare valacyclovir with famciclovir looking at just suppression, you find that valacyclovir does a better job of reducing asymptomatic shedding than famciclovir does. We think this might translate into less likely to transmit to sex partner, but we do know valacyclovir seems to be superior to famciclovir in terms of reducing asymptomatic shedding. And when you look at acyclovir compared to valacyclovir, in this study, 90 patients were randomized to receive doses of acyclovir, either 400 twice a day, 800 3 times a day, or valacyclovir 500 once a day, or 1 gram 3 times a day. And again, they looked at asymptomatic shedding and found that all of these regimens worked better than being on no treatment at all. It looked like the higher doses of valacyclovir did have a better efficacy in reducing asymptomatic shedding. Well, what about topical therapies? I've talked about the oral treatments, acyclovir, valacyclovir, and famciclovir, but of course there are topical agents out there that can be prescribed as well. My take on this is to just say no. Acyclovir does come in an ointment. It's poorly absorbed when it's put on a lesion. It really has not been shown to be effective in normal hosts. Yes, it does show efficacy in immunocompromised hosts, but I would not recommend this for patients with genital herpes. Penciclovir also comes as a topical agent. It has been shown to be superior as compared to placebo for oral herpes, but it's never been evaluated for genital herpes. And there's an over-the-counter agent as well, Abreva, doconazole. This too has been shown to be superior to placebo, but it's not been evaluated for genital herpes. I do not recommend topical therapies. If you're going to treat someone with genital herpes, I would strongly recommend using one of the oral agents that we talked about. But there are all kinds of alternative treatments out there that people are using. All of these can be bought on the internet. All you need is your Visa card, and you too can have a brown paper package on your doorstep with any of these agents advertised on the internet to treat herpes. So you'd be surprised what people are paying money for and purchasing to try to treat their genital herpes. Now let me end in the last few minutes by talking about some of the new developments in herpes management. And I want to touch on two topics. One is a new antiviral that's coming around the corner, and the other is just to give you an update on vaccines. So the new antiviral agent, which is not yet approved and may be available in not too distant future, is called pratilovir. This is a helicase primase inhibitor. It acts differently than does acyclovir, valacyclovir, or famciclovir. It is active against both HSV1 and HSV2, including the thymidine kinase deficient, drug-resistant acyclovir-resistant strains. This drug acts directly on DNA synthesis and doesn't require activation. It's actually been granted FDA Fast Track designation for the treatment of the acyclovir-resistant infections in the immunocompromised hosts. In a study published a few years ago, looking at 156 herpes type 2 patients who were treated with one of 4 regimens with pratilovir, either 5 milligrams, 25 milligrams, or 75 milligrams daily, or 400 milligrams weekly, and compared to placebo. Looking at asymptomatic shedding, they found that the dose of 75 milligrams given once a day had the best efficacy in reducing asymptomatic shedding in patients known to have HSV2. This is, you won't be able to see all the details in this slide, but essentially looking at the 4 different regimens, the dose of 75 milligrams once a day significantly reduced the rate of herpes shedding as well as the amount of virus that was actually being shed. So this did look to be the best regimen with this drug. In another study published not too long ago, pratilovir was compared to valacyclovir for suppression. They took 91 adults and treated them either with pratilovir 100 milligrams daily or valacyclovir 500 milligrams daily. They were followed for a month, and they took 4 genital swabs a day looking for herpes asymptomatic shedding, and they found that pratilovir had a much better efficacy in reducing asymptomatic shedding compared to valacyclovir. So stay tuned. We may see this drug on the horizon available in the not too distant future. And it'll be interesting to see whether this drug will be superior to valacyclovir or whether we'll be using it in combination with one of the other antivirals. Lastly, let me just mention vaccine development. We've been waiting for a vaccine for 20 years, it seems like, and there still is no vaccine on the horizon. You may have heard over the last few years a lot of excitement about the Gen 3 HSV2 vaccine. This was an adjuvant vaccine containing 2 different antigens that was good in inducing T-cell and B-cell immunity. And while the phase 2 trials looked promising, there were unfortunately very disappointing results clinically, and the trials were stopped. And more recently, there was a scandal related to a herpes vaccine. The Cervix trial was a live attenuated vaccine that a researcher was working on. The trial was never FDA approved. The researcher actually flew patients from the US and Canada down to the Caribbean and actually gave vaccine injections in a hotel to try to see if the vaccine would work. This was a scandal, as you can imagine, and this probably set the whole vaccine field back by several years in terms of looking for a herpes vaccine. So let me end just by again reiterating some of the take-home messages on things we need to remember when we're dealing with our patients with suspected or proven genital herpes. First episode herpes, confirm the diagnosis, counsel your patient on the natural history, the classic and atypical clinical features, the potential complications, issues related to asymptomatic shedding and transmission, and of course talk about the treatment and suppression options. My feeling is to treat all patients with first episode herpes with an oral antiviral. Acyclovir, famciclovir, or valacyclovir are all appropriate. There's no role for topical agents, but talk to your patients about the options going forward with either episodic therapy, suppressive therapy, or no therapy at all. For recurrent herpes patients, again, confirm the diagnosis, counsel them, talk to them about transmission issues. You can individualize your management by giving episodic therapy, which will lessen the symptoms and duration of illnesses, or continuous suppression. I like continuous suppression, particularly for sexually active individuals. It gives them a sense of empowerment. They may feel like they're more in control of their virus. And again, intermittent suppression is certainly appropriate in some settings. What I tell my patients is try to know your herpes status and your partner's herpes status, be able to recognize your symptoms, understand the concept of asymptomatic shedding, use suppressive antivirals to prevent transmission, and of course always use condoms. Our patients are scared. They're still terrified of sexually transmitted infections, including herpes. It's our job to provide them with adequate resources. The American Sexual Health Association has a website. The Centers for Disease Control and Prevention has a lot of information. And for those people who can't get enough of the internet, there is a herpes dating service online in which you can go and register, and it's a dating service for people with herpes as well as other sexually transmitted infections. I guess when you finally do get together and hook up at Starbucks, it gives you something to talk about to kind of break the ice. We want to prevent this from happening. You don't want your patients to have to explain that they gave someone herpes and give them an apologetic cake or cookie. And I'll leave you with this thought, and that is to tell your patients, remember that the biggest difference between love and herpes is that herpes is forever. So let me stop here if I could, and I'll be happy to take any questions that you all might have.
Thank you so much, Dr. Ehrlich, for that really informative presentation, and there were a ton of questions. So to everybody that put a question into the chat box, we probably won't get to all of the questions during the next few moments, but Dr. Ehrlich has graciously agreed to respond to them, and the answers to all the questions will be emailed out to participants. But one of the first questions to you is about transmission. So someone wanted to know, is there a difference in transmission if someone is asymptomatic versus someone who has symptomatic lesions? And this person's question was related to sexual transmission to a partner as well as mother-to-child transmission.
That's a great question. It's a great question. All we know is that someone who has active vesicles, who's symptomatic, will have more virus. There's more virus there than what you will find in that person who is shedding asymptomatically. But certainly asymptomatic shedding does result in transmission. I don't think we can actually quantitate it to know how much higher the risk is if you have symptoms, but it would seem to me that it would be higher likelihood of transmission for someone who's having symptoms at that moment.
Great, thank you for that answer. Here's another question. just wondering, is there any research on using valacyclovir for prophylaxis in an HSV uninfected pregnant woman who has a partner who has herpes too? So kind of like, PrEP prophylaxis.
That is a great question. Unfortunately, there's no human data to support the practice of giving someone who is at risk, like a pregnant woman whose partner might have herpes, valacyclovir, to try to prevent her from acquiring the infection. But there is animal data, the animal models, in which if you give an animal one of these drugs, valacyclovir or acyclovir, they're less likely to get infected when they get exposed to the virus. So theoretically, it might make sense. It might actually prevent someone from getting infection if they get exposed and they have antiviral therapy already on board. We don't recommend it. It's not been FDA approved in that regard, and there's no human data to really support that.
Great, thank you. That was really informative. Another question is about serology. Someone was wondering, can you have a false positive herpes HSV2 serology? Could that occur if someone really actually has HSV1?
It's unusual to have a false positive serology. I suppose when we do see the false positive serologies, it tends to be in people with immunologic abnormalities, people with lupus or rheumatoid arthritis or some other autoimmune or collagen vascular disease where they're making antibody to antigens that they haven't yet been exposed to. But the type-specific serologies are accurate enough that somebody who just has HSV1 should not test positive for HSV2. If they test positive for both HSV1 and HSV2, chances are they're actually infected with both virus types. Now, having said that, there's always going to be the possibility of false positive testing. There are a couple of different ways that they do the type-specific serology. If you had someone who tested positive and you really did not believe the results, you might consider doing an actual Western blot assay, which is not commercially available, but research labs can do them, and that would be probably the most accurate gold standard.
Great, thank you for that information. And then I think our final question here, is it possible to present with an initial infection and then not have any outbreak for many years? Kind of what's the natural history?
Yes, absolutely. We used to think that someone would always develop symptoms during their first episode herpes and then always have symptomatic recurrences over time. We now know that that's just not the case. And we know that because of all of the serologic positivity that we see in people who don't recall ever having a symptomatic first episode outbreak. It's certainly possible that someone could have a symptomatic first episode outbreak and never have a symptomatic recurrence for the rest of their life. However, when you look at those individuals, they'll still be shedding virus asymptomatically a certain percentage of the time. And their asymptomatic shedding doesn't seem to be any different from an individual who has frequent recurrences. So if you don't have recurrences, that's great, but that doesn't mean you're not shedding asymptomatically.
Great. Actually, there's one more question that I think would be interesting to answer. Someone was wondering, does having oral HSV decrease the risk of them acquiring genital HSV?
Great question. Yes, there is partial protection from having oral herpes due to HSV1. It partially protects you against getting HSV2, and if you do get HSV2, it's not as severe as somebody who's not had oral HSV1. But it's not complete protection. So having HSV1 is not going to protect you against HSV2. You're still at risk.
Great. Well, thank you so much, Dr. Ehrlich, for this wonderful presentation. For everyone on the line, your questions will be answered. So if you've registered, you'll get an email that will have the answers to this Q&A. And if you haven't registered, I believe the link to do a late registration will be put up on the screen in just a moment. And the next webinar that we'll be hosting is going to be on HPV, so we welcome everyone to stay tuned and have a wonderful day. Thank you so much, Dr. Ehrlich, for your time.
My pleasure. Thank you, everyone.